Let me introduce Philip Tack. Comes from Ghent University in Belgium. He is a health economics researcher. Seems perfectly fitted to presenting on the economic analyses because this is much of his work in Ghent. He holds a master's degree in business engineering and a bachelor's in medicine, and currently working as a researcher at the Department of Public Health Inter-University Center for Health Economics at Ghent University. So we'll welcome Philip.
Okay, so good afternoon. My presentation will have two parts. In the first part, I will give an introduction into health economics, and in the second part, I will continue to talk about health economics for anatomic models of congenital heart diseases. So we all know that innovations are a challenge. So let me start with a quote from the report from the Belgian EU presidency in 2010. Which states, we need to make available and stimulate only those innovative technologies that offer therapeutical or social benefits at an acceptable cost and fulfill unmet medical needs. So basically, we accept that innovations may cost more than the standard of care, but against that benefit, we also should have an improvement in health. So basically, we need to have them cost effective. And when we talk about cost effectiveness, we can quite easily illustrate that. When you see it on the picture, you have on one side the costs, and on the other side you have the health effects, which will be in QALYs, which will come on later. QALYs are quality adjusted life years. So when compared to two technologies, we mostly compare the new technology to the old one, and we put the old one in the middle. So every cost that is implied, additional cost is implied with the new technology, is going to be compared, is going to be a relative extra cost. Same with health effects. It's going to be an extra health effect. So if you have an example of one innovation that is costing quite a lot and is bringing a health effect, but it's quite limited, we will obviously all think like, yeah, no, that's not going to be cost effective. The other way around, if we have an innovation that is bringing some health and also reducing costs, we're going to be thinking, yeah, of course, this is cost effective. And in that case, it will obviously be cost effective. Innovations can also be cheaper than the current technology, and not because the innovation itself is cheaper, but because of the health effect that it brings. For example, if you can reduce complications, which are extremely expensive, then the technology in total could come out cheaper. The question is then, when we have an innovation that is costing more and bringing substantial health effects, where do we put a threshold? What is acceptable costs for what it brings? There we have the question how to put the threshold. Because when we have an increased health, we can actually put more costs to that. And when we are above the threshold, we're going to say that, no, it's not cost effective. And below, we're going to talk about, yes, the technology is cost effective. And when we're below the normal standard of care and price-wise, then we're going to talk about price dominant. So I've talked about QALYs, but I've never explained them. So QALYs are quality adjusted life years. And basically, one QALY would mean that you have 1 year in perfect health. And we don't need always to have that. So you can also have that one QALY takes 2 years or more. Or in our example, on the graph, you see that you have a patient that earning half a QALY a year for over 10 years and totaling up for 5 QALYs. QALYs are measured through standard health questionnaires like the EQ5D and the SF36. So if we have an innovation, and the innovation is improving health, but not lengthening the life. For example, here in our example, we have it's improving a little bit of health and bringing over the course of the 10 years 1 extra QALY. We can have an innovation that is also extending life, but keeping it at the same health level. So then, in our example, if we can extend life for 2 years, then we can also have that extra QALY. If we have a technology that is performing really well and doing both, like in our example, then we can have even more. it's obvious to know that life is not that simple, and we cannot say it's going to be a flat line. And basically, we have to take the surface below the graph to be more correct. So we have the problem for where to put the threshold. What is 1 year in perfect conditions worth? And historically, we've taken 50,000 euros or dollars, they're the same. It's always been like the thing for kidney dialysis, which earns 4 QALYs and costs about 200,000 euros. But recently, as countries are getting wealthier and the price you're willing to pay for 1 year of life in perfect conditions is going up with the healthier you are, the tendency is going up, and it's going up to 100,000 a year and even more. Some argue that 150K a year would be a good idea for QALYs, for the threshold. So if you have some example, when we give training to caregivers of stroke patients, we're on a dominant strategy because it costs less. We don't earn anything, but we can reduce costs. So we're in a dominant position. If we go for example, HIV counseling, we can have something that is cost efficient. Even though it is not bringing that much QALYs, it doesn't cost that much. And then we go to the things that used to be not cost effective, but now we are discussing them, like an annual CT for 6-year-old heavy smokers. There you see that it costs quite a lot, but as our economies are doing better, we can say, like, maybe we can afford to do that. So I've talked about health economics, but I haven't talked about how we evaluate it. And mostly we use simple models, like, for example, this decision tree. I will explain this fictive model quite fast, so you have an idea how we handle things. We always compare to the standard of care, and in this case, we have a standard of care costing 1,000. And our innovative technology and 3D printing, in this example, costs twice as much. If you have a success with the standard of care or with the technology, you only pay the price that you had to pay to use that procedure, for example. In the case of the standard technology, it's here 1,000. In the case of 3D printing, it would be 2,000. Of course, we can have a failure, and against the failure, you always have a cost. And in our example, we take 10,000, which is quite a lot, but often it is the case that, like, complications are quite expensive. Every medical thing can have a success rate and a failure rate. And in our example, we have a failure rate that is quite lower with the new technology of 3D printing. So we can calculate the average cost per patient. And in this case, it would be 4,000 for a normal. We easily can get that through multiplying the success rate with the cost of success and multiplying the failure rate with the cost of failure. And if we go here, we can see that our 3D printing model would be cheaper. So we'll be in a dominant position. Obviously, we're talking about cost, benefits, and other things, but when you have different players, you have different questions and you have different important things. For example, for a doctor, it will be way more important to know what kind of benefit it will be for the patient than to know what kind of cost is standing against it. For the director of a hospital, it will be a bit more the opposite. It will be more thinking about, but what does it cost for me, or where do I have a cost reduction, or what does it bring for the hospital itself? And when we go look at the healthcare provider, he's going to be more thinking like, how can I maximize the health that I'm creating with my budget that is quite limited? So he's going to be looking at cost effectiveness. So that was the part of health economics where we gave a brief introduction. Now we're going to go over to 3D printing. We all know something about 3D printing, and whether it's from printing small toys, like we've seen in the other hall, or printing biomodels or other things, the medical setting has adopted it quite well. In the beginning, we only saw like the validation of the biomodels, and by the end, we see that they can use the models for surgical planning and testing. After that, we see that surgical aids, like this, surgical guides, are getting into shots, and even the tools where you can see all-in-one packages coming up. After that, we have the custom implants, and we all know it, which have tremendous benefits, especially for persons that are at end of the normal care and where the normal implants are not sufficient anymore. Then we have the porous scaffolds, which could be a lead towards the tissue engineering. And in the end, we have drug delivery systems and microscale medical devices. So we're going to talk about the biomodeling in here. So to have a brief overview of how big the integration of the medical 3D printing already is, we conducted a systematic review of all literature available. But we only incorporated the things. We wanted to have an incorporation of the practices that are already pretty well integrated and not all the case studies that are really plenty. So we only took the case series of four, and trials into consideration. And after a duplicate check, we came out with above 5,000 papers. So we screened them on title, we screened them on abstract, and then after full reading, we only had 227 papers left. When we go look at what applications there are, we could see that the surgical guides are the biggest part. And after that, we have implants as well, quite important. When we go see at models, because that's what we're going to talk about today, we can see that we have models for patient selection, which are mostly in cardiovascular applications, accounting for 1% of total 3D printing, and models for implant shaping, which are mostly in maxillofacial surgery, accounting for 3% of all applications. And then we start looking at models for surgery planning, which are the thing we're going to talk about today, which account for 33% at this moment. When you look at it, we can see that maxillofacial surgery is taking the big bunch of it, together with orthopedics and cranial surgery and spinal surgery. And only 9% of it accounts for cardiovascular applications. So we looked at in the literature to find what benefits that the anatomic models would give in cardiovascular surgery. And the first would be like improved diagnostic accuracy and patient selection, which is an obvious one, as we have better representation of what the patient has. Second, improved surgical plan and patient safety was stated quite a lot. Third, we had decreased incidence of complications and errors. And fifth, we had improved surgical and functional outcome, which is quite obvious if you see the three before. All of this leads to decreased hospitalization time, and some claim that it can also lead to decreased radiation exposure in cases where, for example, we put stents in and you have a better visualization and you need less guidance during the procedure. Then we also had the most quoted benefit, and there was OR time reduction. And accompanied with that, we had the decrease of surgical instruments due to the selection up front during the testing. So when we looked at it, we could not find any evidence to support these claims. They were all subjectively ideas of the authors, and we could not find a lot of cost benefits. We could find some claims that of cost effectiveness, but never we didn't ever have numbers to back these up. We could not find any literature about economic evaluations in cardiovascular heart models. And we really feel that it's needed to have good economic evaluations to put these claims into facts. So, in the beginning, we talked about what perspective. So, who is benefiting from the cost? And for this small analysis that we made, we took two perspectives. And the first one would be the hospital, which will be really short. And then the second one is the public health provider. When you go talk about hospital perspective, we're going to talk about how can it be beneficial for the hospital as a whole. So, and cardiovascular models, anatomic models, are often used for simulation, which are quoted to reduce OR time and decrease the number of surgical instruments. Obviously, if we try to reduce the time during the operation, we have a bit more of preparation time, so we have to take these into account as well. So the doctor is going to spend more on preparation. As OR cost is one of the biggest costs, this will be the big key driver. To have an idea of how to simulate it, we had to find numbers, and we could only do that to talk with an expert. And that expert said that we could have an operation reduction in some cases of approximately half an hour. Same with surgical preparation time. The expert estimated that it would also take half an hour of preparation compared to normal procedure. We didn't have any difference in the surgical instruments, which is one of the benefits quoted, because the expert stated that they use big trays which contain all instruments, and they have to be sterilized anyway. So even if we know up front that we're not going to use it, it's not going to make a difference in cost. So the big drivers are the salary of the surgeon, and the OR cost, which we estimate at 80 per minute. If you look at it for half an hour, it's approximately 2,500 euro in the reduction of cost. Against that, we have the more preparation time. And there, the experts stated that no extra costs needed to be made, and there was no equipment needed for that. So only the surgeon's salary was a cost to take into account, which was 33 euros in that case. Obviously, the expert stated that not all procedure will have the benefit of the reduced OR time. So it was quite of a conservative estimate, since we sent out questionnaires to a lot of authors, and we only got 2 back, 2 days ago, so that's one we could not take into account, which was less conservative. But this one said that we had 3%, in 3% of the cases, the model would benefit and it would give a reduction. If you look at it, the cost of a model would be estimated at 1,500 euros, and the preparation cost would be approximately 83 euros, and the surgical difference, which is 3% of that 2,500 euro in reduction of surgical time, we end up with the cost of a model is approximately 1,500 euro for a model. So that's a cost, and we don't have something to put against that at this moment. But obviously that's without selecting the patients right. So if we have a better selection of patients, we can find a point where if we select the patients good, we are actually reducing costs. And in our case, it's approximately 2/3 of the patients. So if we go further, we can go to the public health provider perspective. And there, the simulation would improve the diagnostic accuracy and patient selection, improve surgical plan and patient safety, and decrease incidence of surgical errors. And if you put that into cost or really relevant things, we would come up with one thing, and that's reduction of complications. So that reduction of complication would improve surgical and functional outcome, and also decrease hospitalization time, which is a big cost driver. So basically, because of the reduced complication, we would have a benefit in terms of money, and we would have a benefit in terms of health. So we have decreased healthcare costs and improved health for the patient. When we look at the frequency of the complications, we could find a really good study of Pascali that stated for different procedures the frequency of the complications, and they vary quite a lot. If you look at it, you can see that the line is going up, and it's also in the order of what procedures are more complex. So if you can see, for example, for Norwood procedure, the complication rate is over 75%. The same author also compared the costs to the complications, and we also can see the rising trend here. Again, example, you can have way heavier cost for the more complex procedures. When we associate both of them, we can calculate the average cost that we have to take into account for possible complications. And there we see again that rising trend that where you have the more complex procedure, you have a really big associated cost against the more common procedure where the cost is quite reduced. So if we take the example for Norwood and we put it in a simple anatomic, in a simple model, and again, our expert estimated that 3% that we would have a 3% reduction of these complications, then we could calculate what the cost is of the normal procedure and the procedure with 3D printing. In this case, if we have the normal procedure costing 165K and we add the cost of the 3D printing, which is 1,500 euros, you have the cost of success. Then we have the cost of complications, which is quite high in this case. It's $119,000. So if we have a reduced failure rate of 3% relatively, then we can also calculate what the costs are going to be. The cost of the first is about 255. And when we use 3D printing, in this case, we could actually reduce costs. So basically, we are cost effective at this point. And we are even more than cost effective. We are in a dominant strategy, which can be seen on this graph again. We have lowered costs, and we have increased health. So if we put that into perspective, like what would be the spread if we could reduce more complications or reduce less complications, and we put the cost of the model, and we can see that again, the more simple procedures are not going to benefit that much from the model against the more complex procedures who are going to benefit a lot from it, even with small reductions in complications. Let's do the same example for example, a Fontaine operation. Here, we have an increased cost by using the model of approximately $1,000. But at this point, we have not talked about health benefits. We have only been talking about economic benefits. So we don't know if the health benefit is quite limited for that €1,000 we would invest and result in not cost effectiveness, or if the benefit is actually big enough to say that, yes, it is cost effective. So we have to look into the drivers of qualities, like what could give us more quality. And of course, the decreased incidence of complication would be one of it. Now, at this point, we could not find any evidence of qualities there's never been calculated yet. For a personal point of view, we would estimate that it would be relatively low since complications don't last that long. So also, we have to notice that not a complication could be reduced by using the model. Mechanical and surgical complication linked with anatomy could potentially be avoided. And if we look at the percentages, we see that 5.2% of the reoperations have reoperations, and 5.5% readmissions are due to residual lesions that might have been avoided with the 3D printing. If we look at the literature, we could find that procedure-related complications account for quite big resource uses. So it's in the benefits of reducing them. We have been talking about complications now, but there is one driver that is quite important as well, and that's mortality. Average mortality of congenital heart surgery is quite high. It's 3.4% in average procedure, and with the complex procedure, it's even higher. So if we can say, we found in literature that the quality of life after congenital heart surgery is approximately the same as the general population. And if we can save one life, young life, then we can estimate that we are approximately generating 50 QALYs. And if we go back to the beginning where we talked about what one QALY was worth, and we said that it would be approximately 50K to 100K or more, we can say that saving one life is worth 250K to 500K. So basically, if we save 1 out of 166 patients, or 1 out of 303 patients, if we take the 500K into account, we are cost effective. And we haven't even talked about decreased cost of complications and the loss in qualities because of the complications. So we have a lot of needs in further research to do proper economic evaluations because this was pretty preliminary. So we need to know how much qualities are gained by doing the surgery, and especially split up by the different procedures. We need to know how many qualities are lost due to complications, and especially what kind of complications produce the biggest loss and biggest morbidity afterwards. We need to know the impact on the genetic models, the health economic impact and the surgical impact. So for example, surgical time, the reduction in surgical instruments. We need to know what reduction in complication would be and what mortality reduction would be, and which events would actually be preventable by using these models, because not all events are going to be preventable. And obviously, since preparation time is a bit more higher, we need to know what time surgeons spend and what costs surgeons spend preparing for these procedures. So to conclude, health economics assessments are essential to new technologies and also to 3D printing. At this moment, there are no clinical trials supporting the many claims, and we wouldn't need actual numbers supporting them. There are no health economics evaluations who have been conducted, and not even close to that, actually. So we would need it and split up by every procedure of every pathology. And if we can say something about what we've done in this preliminary evaluation, is that heart models are likely to be cost effective for complex cases. Thank you.